Thank you, everyone, so much for joining us this evening. My name is Dr. Olutayo, and I will be moderating a portion of this talk tonight, along with the Student National Medical Association chapter at Frank Netter School of Medicine. We present to you a Health Disparities in Medicine series, and tonight's topic is on dermatology and skin of color. Today, we will be discussing health disparities that affect minority populations, which are an important aspect of public health. These conversations will be academic, social, medical, and rooted in research, as well as clinical experience in an open forum. Our planning committee includes Mr. John Garcia, Shawnee Green, Madison Masters, myself, and Dr. Listy Thomas. The time is always right to do what is right, from Dr. Martin Luther King Jr. So tonight we will begin with an introduction of our panelists. We will talk about the first article and review it with our student moderators and have a panel discussion regarding that article and ask our panelists to chime in. And we'll repeat this for the second article and then end with a question and answer session. So our panelists, I am so honored to introduce them today. I will start with Dr. Mona Gahara. She is a board certified dermatologist and did her dermatology training at Yale University. She continues to hold a faculty appointment at Yale and sees patients in private practice located near New Haven, Connecticut. Dr. Gahara and her husband, Karen, have two boys, Karen and Jai. Besides mothering and doctoring, Dr. Gahara spends time educating the public on skin health, skin cancer, skin of color, and sun protection. She is an active member of the American Academy of Dermatology, where she chaired the social media task force, the Women's Dermatologic Society, where she serves as president-elect, and the American Society for Dermatological Surgery, where she chairs the Diversity and Equity Inclusion Work Group. We are so happy to have her with us today. Dr. Temitaya Ogunleye is an assistant professor and associate director of Diversity, Equity, and Inclusion of the University of Pennsylvania, Department of Dermatology. She received her medical degree from the University of Pennsylvania, Perelman School of Medicine, completed her residency training at the University of Michigan, and trained at the University of Pennsylvania as a clinical educator fellow. Her areas of interest include skin of color, hair disorders, and increasing diversity in medicine. We are so happy to have her with us today. Next, we have Dr. Sarika Ramachandran. She is the medical director of Yale Medicine Dermatology in Branford, where she treats children, adolescents, and adults for all their general dermatological needs. She also has a special interest in helping people with rheumatologic dermatology conditions, such as cutaneous lupus, scleroderma, and morphea, a condition that causes hardening and discoloration of the skin. She is an assistant professor of dermatology at Yale School of Medicine and is currently researching morphea and new treatments for autoimmune skin diseases such as lupus. We are so honored to have her with us today. And we also have with us Dr. Elena James, MD, PhD. She joined the faculty at the Department of Dermatology in 2012 at the University of Pittsburgh. She completed her undergraduate degree in molecular biophysics and biochemistry from Yale University, and she simultaneously earned her medical degree and PhD in cellular biology at Baylor College of Medicine. Prior to joining the Department of Dermatology, Dr. James was a faculty member at the University of Pennsylvania's Department of Dermatology. We are so happy to have you with us today. Thank you to all our esteemed panelists, and we're really excited for a great discussion. So I would like to introduce our student moderators, Ms. Shawnee Green and Ms. Lillian James, class of 2024 at the Netter School of Medicine in North Haven, Connecticut. Ms. Shawnee is the SNMA chapter vice president, and Lillian James is the SNMA chapter secretary. These are our future, and I'm excited for them to be colleagues of mine one day. So I'm actually going to turn it over to Shawnee Green, and we'll go ahead and get our discussion started.
Thank you, Dr. Sabunro, and thank you everyone for joining us tonight. So to start us off, we have this quote: "There is a 20 to 30-fold lower incidence of melanoma in skin of color compared to non-Hispanic whites. However, data from the National Center for Health Statistics suggests that for every 3 Black men or women diagnosed with melanoma in the US, one dies of the disease. By contrast, for non-Hispanic white men and women with melanoma, roughly 1 in 7 and 1 in 11 die, respectively. So the first article that we're going to discuss tonight is titled Basal Cell Carcinoma, Squamous Cell Carcinoma, and Cutaneous Melanoma in Skin of Color Patients by Ms. Latrice Huff and Dr. Valerie Harvey. So this was published in the Dermatologic Clinics Journal in 2019. And so we just highlighted a few main points from the article. So skin cancer is more common in fair-skinned individuals. However, the large disparities in patient outcomes makes them an important public health concern. Basal cell carcinoma, squamous cell carcinoma, and melanoma combined are the most common malignancies in the United States. Squamous cell carcinoma is the most common skin cancer in Black individuals, which accounts for 20% of skin cancers. Basal cell carcinoma in Black, Hispanic, and Asian individuals tends to be pigmented and often misdiagnosed. Minority patients diagnosed with melanoma are more likely to present with regional and distant metastases. Early detection and research are important to help reduce disparities in these skin cancer-related outcomes. And then just a quick note, if you guys have any questions, just put them in the chat and we'll answer them at the end. Okay, so for our first question, Black patients are often diagnosed with skin cancers in the later stages. With melanoma specifically, there's an increased risk for metastasis, ultimately leading to worse patient outcomes. Dr. Ogunleye, based on your personal experience, do you believe residency programs adequately train their residents to treat skin of color? In what ways can they improve?
I think the question is interesting because we wouldn't be here if we were adequately training our residents to appropriately diagnose skin conditions in darker skin tones, right? So the answer to that is no. So we're not doing a great job at it, but it's something that we're working on. And I think that the things that we need to do to improve is just basically being intentional, right? So we need to be intentional in the way that we are thinking about treating disease in skin of color patients. So the same way that we're intentional about treating psoriasis and intentional about treating, eczema, we have to be really intentional about the way we teach our residents to identify things in darker skin tones. I think, and that is kind of widespread. So that's, thinking about the way that we, particularly, I would say that that's important when we're thinking about residencies that are in places that aren't as diverse. When you're in a residency program in a city or a town that is more diverse, just by virtue of seeing patients of color, you're going to have a little bit more experience. But if you're training somewhere where you don't see as much darker skin, you have to be more intentional about getting that education. And so that's making sure that our literature is representative of all skin tones. So when we're seeing things and, like, let's say we're talking about psoriasis, we have to make sure that we're showing images of psoriasis in darker skin tones, of eczema in darker skin tones so that people can recognize it. And I think it also is about the language that we use. When we talk about kind of different skin conditions, we use terms like erythematous or pink, and those types of terms may not apply as readily in darker skin tones as well. So we have to really kind of widen the way that we kind of describe patients as well. And then I think that we also have to just think about the way that we are, I think there's one person that may be unmuted. Thanks. And so we also just have to think about also the way that we are, generally, like I think in literature, the way that we are making sure that all of our patients are included in the literature that we're publishing. So when we're doing studies and doing clinical studies on things like melanoma, making sure that there are representations from all skin tones so that the treatments that we're using and the things that we're studying are applicable to all, skin types and ethnic groups.
Thank you so much for that answer, Dr. Ogunleye. So for our second question, 65% of people of color view themselves as having no risk of getting skin cancer, with Black and Hispanic patients being less likely than other groups to believe that behavioral practices can affect their skin cancer risk. Dr. Ramachandran, in what ways can primary care teams educate their patients on the risk and prevention of skin cancers?
Thank you so much for the question, and thank you so much for having me here. It's an honor to be here. Um, So in terms of what can primary care do? Primary care is really our first line in terms of how we can help patients with their skin. And so one of the things I think is really important for primary care teams to help our patients with is to bring awareness to patients with skin of color that skin cancer can in fact occur in all skin types. So one thing is really to note to the patients during the visit that they should be looking at their skin and observing things that may not look typical or things that may be concerning. So, teaching patients what can skin cancer look like, and specifically what can skin cancer look like in darker skin tones, because it can look very different in darker skin tones compared to lighter skin tones. And so it's important to bring that up as well. Other things are, where does skin cancer occur? So skin cancer in darker skin types can occur in the hands, the feet, places that may not be sun exposed. So looking in those areas for skin cancer to occur. So primary care can help to educate our patients in terms of where to look for skin cancers. Also, I think one of the most important things is to let patients know that it's okay to bring up concerns and to ask about lesions that they may have questions about. So, really, to encourage patients to bring up their concerns to their primary care team. And so, those I think are very good starts. Now, other things are, of course, bringing up what are good habits in terms of sun protection. It's important to kind of go over what can sun protective measures be, what are good ways of protecting our skin from damage that the sun can cause, how to use sunscreen, when to use sunscreen, sun protective clothing, those types of things. So I think those are all places where primary care can really help to educate patients, particularly patients with skin of color, that skin cancer can in fact affect everyone, and that we should be looking and if there are lesions that are worrisome, they should be brought up to primary care. And of course, if there are lesions that are concerning to our primary care teams, to educate the patients that a referral to a dermatologist, if it's needed, can also be done, and is also always an option. So I think those are some very kind of basic places to start. And I really, I applaud our primary care teams that always, do try to start as the first line of helping our patients with the skin. But I really hope that in the future that we can show all of our patients, but especially our patients with skin of color, that it's important to be aware of the risks of skin cancer, and that there are ways and practices that we can participate in terms of sun protection that can be, applicable to all skin types.
Thank you so much. For our next question, skin of color is often underrepresented in medical literature, leading to undiagnosed or misdiagnosed conditions. Dr. Gohara, what are some ways that physicians can improve clinical outcomes in patients with skin of color?
So first of all, thank you so much. I just want to echo Dr. Ramachandran's thanks. I appreciate that you guys reached out to me. I'm right down the road from many of you in Connecticut. So it's an honor to be here, an honor to be with my other colleagues here. This is a great question. I think this is, first of all, a great way to kind of a great forum as well. So congratulations to you. So what are ways that physicians can improve clinical outcomes in patients with skin of color? I think the first way is for clinicians to be educated on how to take care of skin of color, and how to be educating our patients of skin of color. I will tell you that I run a medical practice, and I see tons of patients for skin checks every single day. I see a lot of men and women with brown and black skin, but not a lot of men and women for brown and black skin for skin cancer screenings. So they come in for other reasons, such as acne or eczema or psoriasis or whatever the problem may be. And it takes my initiation to say, I think we should do a skin cancer screening on you, because I believe that everybody over 40 should be getting skin cancer screenings, and it's easy and quick to do. So if it takes my initiation to do that, you would hope that others are doing the same thing. And I don't know that that's the case. So I think that one of the most important ways to improve clinical outcomes is for us as physicians to educate ourselves and to know that, of course, brown and black people can get skin cancer. Of course, it's more deadly. Because why? It's not diagnosed on time because people aren't, both as physicians and patients, are not looking for it. So that's why I think it's critical that I think one of my colleagues said this earlier is that starting in med school and residency, we need to put everybody on the same playing field when it comes to how we approach patients with skin cancer prevention and skin health. And right now, that is not the case. I guarantee that many residents are not learning that brown and black patients should be getting skin cancer screenings like their white counterparts starting at age 40. So we need to change the paradigm and do that. We also need to change kind of like the public relation kind of aspect of this, because and remember one critical point, that ethnicity does not confer skin type. So somebody who identifies as black could be very, very, very ethnically, they identify as black, could be very, very, very light and have just as much of a risk of skin cancer as somebody who ethnically identifies as white. And so we have to remind ourselves that ethnicity and skin type, skin color, are not necessarily like always aligned with what we think is the case, and that there's diversity within diversity and many different skin types and skin tones. And everybody, again, should be on the same playing field to be getting skin cancer screenings, and more importantly, practicing sun protection, good sun protection habits. Again, this is not information that we should just be disseminating to our white patients. This should be information about sunscreen that we are disseminating to our black and brown patients. And we need to do it in a way that is going to fit into their lifestyle. So I'm not going to wear a sunscreen that's going to leave me looking like Casper the Ghost. It's not going to happen. I'm not going to do it because it's not cosmetically elegant. I don't want to walk around town looking like, white chalky stuff all over my face. So again, we have to train our colleagues to not just say, hey, use sunscreen. No, offer some sunscreens that will be cosmetically elegant, that will blend nicely into black and brown skin, making it more likely that our patients of color will use it. So I think that the onus lies on us, to answer your question. The onus lies on us as physicians to educate ourselves and our colleagues, to put everybody on the same playing field, to make sure that we're understanding what kind of products like sunscreen are going to be cosmetically elegant and fit into the lifestyle of a person with melanin-rich skin. And to be honest with you, to make sure that everybody is getting skin cancer screenings and knowing the signs of what skin cancer in black and brown skin looks like.
Thank you so much, Dr. Gohara. And so for our last question, Dr. Gohara just gave us a great answer about ways to improve clinical outcomes. Can you give us any insight into current projects that are being implemented to increase representation of skin of color in textbooks, clinical research, and educational materials?
Yes. Thank you so much for having me. These are great questions, great points that all of the panelists are making. We, in particular, are working on a project called Visual Learning Equity, and that looks specifically at all learning materials, and it rates and it categorizes the different colors that are represented. And we strictly, as was mentioned, look at color and not race being the social construct that it is. We look at color to see what color is represented in all levels of educational materials, both for patients as well as for health professionals. And what we've found that agrees with other studies is that about 70 to 80% of all visual learning images are of white skin. So there's white centering of what we're learning. And there's around 15% or so to 20% of medium or tan brown skin. And then a very dark or black skin, there's very few images in learning material. And this goes from dermatology textbooks to medical education, to the journals that we use to look at in the classroom, all across. We've also done a look at Google, Yahoo, and Bing, looking at the search engines. When you look and take a look at psoriasis or hives, it's white centering. And so we really have to go beyond just what we're doing locally at our institutions, but we have to look at it on a societal level this big impact in what is represented. And I see it as a form of visual racism. And so we have to go to our leadership at our institutions. We have to go to Google, and we've had conversations with them about changing race-biased or color-biased search algorithms. And this is really, really important, not just for our learning, but for the advancement of technology. With artificial intelligence, a lot of the training that's happening for these new, technologies are based on databases that are white-centered. So, and this goes across the line from skin cancer to inflammatory diseases. And the other interesting fact is that there's overrepresentation of darker skin when it has to do with sexually transmitted infections. Or so there's another bias that's being learned as well. So it's across the board, not just skin cancer. It's all throughout visual learning. It's all throughout, immunology, other fields, rheumatology, the images that are shown. And so I think that there's multiple levels of attack that we need to address this issue, again, on a small scale at our institutions, but also in our board meetings, the editors of textbooks, the editors of our journals, so that we are all advancing and making healthcare visually equitable.
Thank you so much for that answer, Dr. James. And now I'm going to hand it over to Lillian, who's going to go over the second article with us.
Thank you, Shauna. And thank you to our panelists, of course, for being here. And thank you to everyone else that was able to join our discussion tonight. Our second article is titled How Dermatology is Failing Melanoma Patients with Skin of Color. This was published in the Cancer Cytopathology Journal in 2020, and this one was written by Brian Nelson. So dermatologists suggest that disproportionately high melanoma mortality rates in patients with skin of color may be driven by lack of representation and data in awareness campaigns, in clinical research, and in the field of dermatology itself. One debated uncertainty is whether UV exposure plays a meaningful role in melanoma risk for people with skin of color. Initial studies suggesting a strong association between UV exposure and melanoma risk largely excluded participants with darker skin types. Efforts to give health advice for proper skincare have been complicated by a lack of diversity in dermatology, which has the second lowest percentage of underrepresented minority physicians among medical specialties, with only orthopedics having a lower percentage. There is also a national shortage of dermatologists familiar with skin of color because of lack of recruitment and inadequate training. Lastly, studies suggest that Black patients are significantly more likely to be diagnosed with later stage melanomas than their white counterparts, and this makes them harder to treat. For example, a 2017 report found that the risk of surgical delay, which is surgical excision performed more than 6 weeks after the diagnosis, was significantly higher in non-white patients than white patients, and those with Medicaid than those with private insurance. So to move on to our first question, the field of dermatology has the second lowest percentage of underrepresented minority physicians among specialties. Dr. Gohara, what are some barriers underrepresented medical students face when pursuing a career in dermatology? How can we mitigate these barriers and improve the diversity in the field of dermatology?
This is a great question. And I just want to apologize in advance because I actually have to moderate another panel. So after this, I have to drop off. So I apologize for that. But so this is a great question. And as you mentioned, dermatology is the second to least diverse specialty, only second to orthopedic surgery. And this is a trend that's been happening for many years. If you kind of go back, when you look at the number of Black and brown, this is AAMC data, actually, medical students, and this is not for this year, this was for the last year match cycle. I think there were only like 60-something Black medical students who applied to dermatology, and maybe only like 30-something Latinx medical students who applied to dermatology, according to AAMC data, out of like 700 applicants. I mean, those numbers are dismal. And so a lot of people obviously are invested into figuring out why, and the needle is moving. But previously, it actually really wasn't. You go back and look at medical school experiences of Black and brown med students, and Black and brown med students, because of institutional bias in the med schools, oftentimes are less likely to be AOA, oftentimes are less likely to get honors in their med courses. Again, all because of institutional biases largely. So what are the criteria that people use to choose dermatology residents? AOA, board scores, who's getting honors in their medical school classes. So the other thing is representation matters. When you look at faculty across a lot of academic programs, there's a much smaller number of Black and brown faculty members, who are interviewing the dermatology applicants than white colleagues. And when you look at even the trajectory in an academic institution, Black and brown faculty members are less likely within the institution to be promoted. So all of these factors really play lack of representation in academic faculty, some barriers in medical school as a result of institutional and kind of institutionalized biases make it tricky. There was actually a study from out of Albert Einstein, that asked underrepresented in medicine med students why they weren't applying to dermatology. It was a survey of like 200 people. The biggest barriers were a lack of mentorship, a lack of representation within the specialty, and believe it or not, socioeconomic barriers. Do you guys know, you write in the chat on average how much you think it costs for one derm applicant? Now, this was back in the day when people had to travel around on airplanes and Zoom wasn't a thing. If you want to take a guess, it's about $10,000 for the average med student to apply to dermatology residency, because people are flying around the country to go to any program. This has dramatically changed, actually, though, I would say in the past couple of years. And now we're looking at dermatology applications from a holistic approach as opposed to just based on numbers. And Dr. Henry Lim, who was president of the AAD a couple, 3 or 4 years ago, really kind of began to talk about this as a responsibility of dermatology programs to really change the paradigm of how they approach the application process. So now, instead of board scores and AOA and honors, all of which are very important still, and research, all of that's important, there's also a component of grit and what somebody's been, what somebody's experienced in their life. And so I think that we're changing this paradigm and recognizing that there is a stark and a big problem that needs to be addressed.
Thank you so much for that thoughtful answer, and thank you for joining us tonight. I know you said you had to go, so we appreciate your time.
Thank you.
Absolutely. And just a reminder to everyone else listening in, you are more than welcome to put your questions in the chat. We will make sure we get to them at the end. So moving on to question number 2. Studies suggest that Black patients are significantly more likely to be diagnosed with later stage melanomas than their white counterparts, and that makes them harder to treat. Dr. Ogunleye, could you provide a specific scenario where a patient was diagnosed at a later stage or had a delay in treatment or surgery that affected their outcome?
You know how many times I do Zoom and always talk when I'm on mute. It's funny, when I got this question, I had to think, and I said, I don't actually think I have a personal patient experience, but I think that when you look at the article and you think about the articles that have been written about patients of color with melanoma, you can see the multiple kind of areas where bias can play a role, or access can play a role in kind of delaying treatment. So, I think Dr. Gohara kind of mentioned this idea of patients not thinking that they need skin exams, or not getting skin exams, or not recognizing the signs of skin cancer. So I think, part of the delay of treatment is, in some ways, or delay in diagnosis in some ways, is because patients don't know what to look for, right? So patients don't know that this line on their nail may be abnormal. They don't know that this pigment on their foot is abnormal, or maybe they're not looking at their hands or feet to even pay attention for those signs of, potential diagnosis of melanoma. So I think that that's one kind of potential delay that kind of, can occur. And I think the next delay is for a lot of patients is access, right? So if you're in an area where there isn't a lot of access to dermatologists, or, a lot of, I think even the study that, we read today talked about the fact that Medicaid patients have, a longer delay in treatment. And so they, in dermatology particularly, Medicaid is not accepted at all dermatologist office, right? So a lot of patients are limited to being seen at kind of academic centers, or, just private practices that will accept, various types of insurance. And so if you are limited to being only seen in certain types of practices, and then you have to wait longer to be seen in those practices, then that is further delaying, your access to treatment and diagnosis. And then, I think even once patients are seen in the clinic and that diagnosis is made, there's still a delay in treatment. And so I think also in this study, there was a study in the AAD that was like from 2020 that looked at delay in treatments. And they said that basically Black patients waited twice as long for treatment, even after being diagnosed. And that was independent of, when they looked at socioeconomic status, when they looked at healthcare coverage. So there still is a delay in diagnosis, even once patients are diagnosed. And the authors of that study, they talked about this idea that it was, possibly due to the fact that when Black patients are diagnosed, they have more complex and later stage and more complex melanomas to treat. And so perhaps that was, contributing to the delay in treatment, because you had to coordinate more, kind of maybe plastics need to be coordinated and different things had to be coordinated to, kind of coordinate their care. But I think that the idea is that there's still an element of bias, right? Something is happening where we're still delaying the care once patients are diagnosed. And maybe it's just like, it takes longer to reach the patient, or maybe it's not something that you're thinking is a priority. But I think that, what we really need to do is just think at these different kind of roadblocks that patients are meeting when they're either being diagnosed or being treated, and making sure that we're appropriately, kind of addressing issues such as access, or, public health issues such as, recognition, or making sure that we are being expedient in the type of care that we're providing to patients.
Thank you so much. So I'm actually going to direct the same question to Dr. Ramachandran. Same thing, specific scenario where they were diagnosed later, or a delay in treatment that might have affected their outcome.
Thanks for the question. So I did have a patient a few years ago who actually came in for a concern unrelated actually to a skin check, and unrelated to concern for a skin lesion, and was concerned about an inflammatory condition or a rash. She mentioned that she had a lesion on her foot that had changed over time, and subsequently she was diagnosed with a melanoma. Now, the patient did not realize that she could, in fact, be affected by melanoma. She didn't realize that patients with darker skin types could have melanomas, and didn't realize that, in particular, those melanomas could affect areas such as the hands or feet. And so this was, really a patient who did not who it was a patient who did not receive education from physician visits, or public education, that this was something that could affect them. So I remember thinking very clearly during that encounter that it really is important as a dermatologist to make sure that all of my patients, regardless of what they're coming in for, whether it's a rash or other types of things, that they are really aware that we should be looking and thinking about skin cancer occurring in all skin types. And so, that was an example of a patient who ended up having a melanoma, and she was treated successfully and did quite well. But I also can think of examples where I had patients with darker skin types who actually presented with our other common types of skin cancers. Squamous cell skin cancer. I had a patient who thought for a very long time that he had a wart on his lower leg. And when I met him, he took out this lesion that was about 5 centimeters, and it was a squamous cell carcinoma on his lower leg. And he ended up having metastatic disease, a very young patient. But again, a patient who really for a very long time thought that this was a wart. And so another case where there was a little bit of a later diagnosis and really affected his care because he was somebody that did have metastatic disease. And then, finally with basal cell skin cancer, I had a patient who actually had a genetic defect that made her more prone to basal cell skin cancers. And she had all these lesions on her face and other places. And she did not realize these were basal cell skin cancers. And these had occurred due to a genetic defect, a type of skin disease that can make you more prone to basal cell skin cancers. And so, in thinking about this question, I thought through my patients, and I realized that I actually have come across in these last few years that I've practiced patients that have unfortunately experienced all three of our most common types of skin cancers. So, all that being said, I thought, especially with the first lesion that I mentioned with the melanoma, I really thought, as a dermatologist, it's so important to make sure that all of our patients know that a skin screening is available and recommended. And so I think, making sure that patients know that they are at risk, but also to know, where can these lesions occur? So, we have lesions that can occur in, sun areas that are exposed to the sun, but also areas that are not, areas that are sun protected. And that's something to really be aware of. And then also thinking about patients that might be at higher risk. So, we have a lot of patients that may come in for something like hidradenitis. And those patients, or patients who have burns, or patients who have other chronic inflammatory conditions, or transplant patients, and these patients are at an increased risk of skin cancer. And so to make sure that our patients are aware that these conditions can put them at an increased risk, and that, our darker skin patients know that we really it's really important for us to be looking for lesions that are of concern.
Thank you so much for sharing the stories. So this is our last question of the night for this article and for all of our articles. So there's a shortage of dermatologists familiar with skin of color because of lack of recruitment and inadequate training. Dr. James, could you discuss the exposure you had in your medical school education to dermatological conditions prior to applying to your specialty? And what would you have changed?
I think most of the themes have been sort of presented, and I think the most important one for me would have been mentorship. I knew when I was exposed to skin disease and dermatology and medical education that it was very attractive to me and that it was something that I wanted to pursue. But what I did not know was the pathway to pursue it, and what were the steps and what were the crucial points, and what did I need to do to make myself a competitive applicant. And it was a lot of trial and error. And so if, the exposure, the learning, I knew that it was deficient in skin of color. That was really obvious to me. And that's what was one of the themes that I wanted to make a difference and fill this gap in what was being taught. But the biggest challenge for me was actually getting to my field of interest and figuring out how to do that. And so that's a really important part of what I do, is mentoring students from middle school to high school to the undergrad level to medical students, to really get them excited about the medical field and dermatology in particular, and to raise their awareness and their knowledge about skin health, and to see that as a career option for them to see. We often go into schools with other medical students and they see someone who's close in their age and say, I could be like this person. And seeing that image, I think, is really important, and giving that idea or a thought into someone when they're young that this is a career path that you can have, and showing that we believe that they can do that. I think is really impactful. So I really want to make the pathway to dermatology a lot easier for people who are interested in it, and to see diversity grow in the field so that a lot of the issues and problems that have existed for long periods of time, when we get really diverse group of people seated at a table, then we see different perspectives and we see different, lack of, interest in different fields of research. And so that will be a bonus to our field when we're able to draw in people who have different lived experiences and have different interests into our field. So mentorship is a huge area that we need to work on in order to diversify our field.
Thank you so much. As I said, that was our last question. I'm going to pass it to Dr. Sagruno now.
Thank you so much to our panelists. That was very informative, and I really appreciate all of you really presenting that information to us in a very thoughtful and really inspiring manner. So I would like to go ahead and open the question and answer session up. I am going to turn it to John, who is the SNMA president, and he'll go ahead and kind of moderate the Q&A session for us. And we are still taking questions from the chat, so please feel free to add them.
Before we get into the Q&A, Dr. Ogunleye, did you want to add something, or said that you?
I did raise my hand. I actually wanted to co-sign on what Dr. James said about kind of mentorship and representation, because I am that kind of part of the pipeline. Dr. James was my mentor when I was a medical student. She gave me a project. She taught me how. She read my personal statement that was probably horrible, and kind of edited it over and over again. Elena, you're laughing, but it's true. So I think it's really important when you talk about this idea of representation, this idea of mentorship, and also this idea of paying it forward. Because Dr. James, Elena is the reason why I went into dermatology. I was a medical student who did my rotation, and I saw her and I was like, oh, I want to be her. And she mentored me, and here I am, 10 years later, and I'm a dermatologist, and we're sitting on the same panel. So I think it's just really important to really think about this idea of mentorship, representation, and what it means when you see someone who looks like you and is doing amazing things, and is also willing to give of their time and give of themselves to, make sure that you're successful as well. So thank you, Elena.
Thank you. It's so amazing to be on this panel with you and to see how you've grown and developed. And that's the one other thing that's beautiful about mentorship, is that it's a mutually beneficial relationship. And mentors, we get so much out of just learning from you and hearing from you and the questions that are asked and pushing us forward. And, so we're motivated just as much. And I'm so proud of you and what you're doing. So it's awesome.
So appreciative.
I just wanted to chime in right now. I didn't even know that fact. And I'm sitting here and I'm just so excited, because this is what paying it forward means. And I just want to throw that out to all the students who are on here, that we didn't plan that, right? That right there was beautiful. And just to see that in real life is amazing. So thank you both.
Definitely. Thank you for being here. Hopefully we can continue to inspire and serve as inspiration for many of the people that are on the call here today. We'll go on to some of the questions that are received in the chat. One of them was asking about specific products that could be recommended for sunscreen for patients of color. And I saw that someone mentioned Black Girl Sunscreen brand. Are there any additional products or brands that would be recommended? And this is for anyone.
I would, basically for sunscreen, I have a couple of brands that I recommend specifically, but I mean, generally to recommend chemical sunscreen. So anything that has a physical sunscreen is going to make you look more gray. I think somebody mentioned kind of looking like Casper. I call it looking like the Gross Sisters from the Proud Family, like you're walking around looking purple. So we don't like being purple. And so if you're going to, if you're using a physical sunscreen, you are going to look more purple. So Black Girl Sunscreen is mostly a chemical sunscreen. So anything that has zinc oxide, titanium dioxide, those will tend to make you look a little bit more purple, but there are some brands that are a little bit more elegant. Supergoop is one that I tend to recommend. There's another brand called Biossance. They're a little bit more expensive, but generally, I usually tell people that if they're looking for a sunscreen that will not make them look as gray, that they should look for ones that have mostly chemical sunscreens in them.
I agree. I agree with those recommendations. And the other thing that I would also highlight is, using other forms of sun protection, such as, big, wide brimmed hats, especially if you're going on like a sunny vacation, some of the sun protective clothing, and so those are some other ways to kind of avoid, the changes you can see with some of the physical blockers.
I agree as well. And then there are some tinted sunscreens that are a little bit higher price point that you can get that color match specific to the skin color or the skin tone. And some of those are iron oxide based. And so they can blend in really nicely, more for the face and the neck area just because of the higher price point. But those you can match specifically.
Thank you for answering that. So another question that we received was, so we discussed some of the barriers for students of color in getting into dermatology. Are there any barriers for physician faculty of color in dermatology in regards to career development and promotion?
Yes. So I will start off and say it's more of the same thing. It's so and the numbers tell the story, like our other panelists were saying. As you go along in academia, you see a drastic drop off of diversity, as well as gender-wise, men versus women in when you go from assistant, associate, full professor, chair. The numbers are, amazing if you look at the data. And so it's another pathway, right? And if you don't really have the inside scoop of what you need to do or the support you need to do it, it can be challenging. And it's especially true with dermatology, which is high volume. So we see a lot of patients. We care for a lot of patients. And that can occupy a lot of your time, depending on what sort of career pathway you're on. And so, again, it's really important, no matter where you are in your career, and I think Michelle Obama said it best, is to have somebody who is in front of you, who is helping to guide you along your path, and have someone behind you who you are pulling forward. And so depending on where you are, you have to seek out mentors, people to sponsor you. And that, for me, took me out of my comfort level, because I would literally have to go and approach people and talk to them and say, I'm not quite sure if I'm, preparing myself, building my portfolio well enough. What do I need to do? And so being able to advocate for yourself for 5, 6 that you need to do, and then finding the support to make it happen. And because dermatology is so small, I found myself having to go to other fields, and I've had to get a lot of support from my colleagues in internal medicine, in other departments, and networking with them and collaborating to get the support that I needed.
I think that I really appreciated your sentiments, Dr. James. It's so true, because dermatology is such a small field. It's sometimes almost imperative to seek mentorship and to ask and to which can be quite a burden on the person asking, and a little bit almost intimidating. And one of the things that I always say to the medical students that I work with and the medical students that I've been lucky to mentor is, if you can dream it, you can do it. And it's not always an easy path, but what I would encourage anybody that's here that's interested in dermatology is to reach out to any one of us or anybody that's doing something that inspires you. If you're interested in dermatology and that's something that you think might be something you want to do as a career, please reach out to me. If I can help in any way, I would I echo the sentiments of paying it forward, that mentorship has, in my life, made such a difference. And some of the mentors have shaped what my life is today. And so I really would encourage anybody here that thinks, maybe I want to be a dermatologist, even if there's like a little thought there, I would really encourage you to reach out to any one of us, or anybody really that's doing something that inspires you, that you think maybe you want to do in the future.
Thank you so much for offering that, because that's really like an olive branch to students, because a lot of times, as a student, medical student, pre-med, you're like, I don't know if I should approach them, I don't know. But what students need to realize is we were all them one day. We were all in the same position. So you guys heard from our expert panelists, so don't lose out on that opportunity. Make sure you contact them.
So another question that we got in the chat is if there's any data around skin bleaching and if it predisposes patients to melanoma.
I can answer that. So not to my knowledge. So skin bleaching, is for those of you who aren't aware, just a way of lightening the skin for the purposes of usually gaining some type of social capital, or whether it be beauty or status, marriageability, all types of things. And so it does not increase your risk of melanoma. I suppose if you were light enough, you would maybe increase your risk of getting kind of sun damage, because you're kind of reducing your melanin kind of capacity. But no, it does not increase your risk of melanoma.
Thank you for that. There's also a question. What are some good resources you have found in those for those that are trying to learn more about recognizing dermatological conditions in skin of color?
Until we have, well integrated, skin color spectrum in mainstream, we have excellent skin of color textbooks that do a phenomenal job of showing, using inclusive language to describe beautiful examples of what skin of color can look like. So there's a wide variety of skin of color specific books. And then there's also some apps and some databases. There's Mind the Gap. There is Visual DX, which has a good reference point for skin of color images, a wide variety, a big database. So there are some skin of color specific areas where you can find a lot of information. There's also the Skin of Color Society that has a lot of good reference material as well.
I think there are a lot of excellent textbooks, and one of the ones that I really find really useful is something called the Dermatology Atlas for Skin of Color, which specifically has lots of images, and I think that's very helpful. I also, when when I do some of my teaching, one of the recommendations I make to my students is to also sit by the computer when you're looking up skin conditions, meaning look up different images. You have to be a little bit careful when you're using the internet, because you want to make sure that you're looking at the condition that they say it is, but looking through those different images to look for different skin types and how those conditions are represented in different skin types. So trying to look at kind of a plethora of images while you're studying, so that you're able to see different images of that entity. So I think there's still a lot of gaps in terms of how much representation there is of different skin types, but trying to look at as many images as you're studying a condition can help to give you different reference points in terms of what to look for when you're in the clinic, when you're trying to recognize a skin disease, and also when you're trying to treat it.
Thank you for answering that. There's a question asking, what factors did you consider when deciding between entering academic medicine and private practice?
Well, I think you have to really, at least for me personally, I think I considered kind of what I wanted my practice to look like and the kind of atmosphere I wanted to be in. I knew that I wanted to pay it forward. So I wanted to, be able to have a lot of interaction with medical students. I know I've always enjoyed teaching, so I wanted to be in an atmosphere where I'd have a lot of access to do that as well. Admittedly, I think even out of residency, I was kind of uncomfortable being on my own. I'm not going to. I'm going to be honest, and I wanted to be in an environment where I'd be with other attendings who were experts in their fields and where I'd have the opportunity to really kind of have access to, my colleagues and, asking questions and kind of, being comfortable in that setting. And even now I'm 10 years out, I'm still in academics because I just still really enjoy, I enjoy the practice of academics. I enjoy seeing patients, but I still really do enjoy, interacting with students, interacting with residents, and really being part of the education and kind of what we're talking about today, making sure that our education is inclusive and being part of that, being part of that solution.
I agree. I think that you have to sort of know yourself and what your interests are and what sort of setting it works well for you. It's amazing to me being on an academic campus. I mean, I find myself collaborating with folks in public health, our social work. I do a lot of community service and outreach. And I feel pretty supported from the institution to do this work. So I always wanted to be a bridge between well-resourced areas and less resourced areas. And I do, hold, our institutions accountable for taking care of our vulnerable population. So I feel like I can be a bridge between the community and the needs of the community and the resources, the rich resources we really have at the institution to make that relationship better and that engagement with our communities better.
I mentioned before, kind of like one of the mottos that I always think of, which is, if you can dream it, you can do it. And I give an example of a few years ago. I had a medical student who I was working with, wanted to spend the year working with me, who was interested in rheumatologic dermatology, which I specialize in. And he was planning to spend the year with me. And I was thrilled that he was going to work on some of the things that I had been working on. But I remember I said to him, I'm so happy that you're here. They're going to be doing research with me this year. But I would love for you to do something that you feel very, very passionate about, that you're excited about, that you've dreamed of doing, because you have this year where you're going to spend doing research. And really, you can spend this year doing anything that you might have thought you wanted to do during your medical school career. And so the medical student thought and came back to me about a week or 2 weeks later and said, I'm really interested in putting on a skin cancer screening for the underserved, for patients who may not have access to to resources, who may not be receiving skin cancer screenings. And so that year we worked on a project with our other Yale medical students to put on a skin cancer screening that was really geared towards the homeless population in New Haven, and really populations that were underinsured or not insured at all. And it was, it was the first year, and we worked on an educational component that we also presented in Spanish. And it was just such an exciting project to be working on. And I remember thinking, he was so excited that he was able to do this, but I remember thinking as a faculty member, how inspired I was that this was something that I got to work on with the medical student. And so for me, being in academics, I feel like I am inspired by the people around me every single day. And I always go back to this phrase, if you can dream it, you can do it. And so, Dr. James mentioned having these resources to be able to do some of some different things, or things that you've dreamed of doing, and or have hoped to do, collaborating with other departments, or getting to work with different people and different individuals, and working on different and interesting projects. I think all of those things are things that I really appreciate and enjoy, being in academics for.
Thank you so much to our panelists. This has been absolutely excellent. We have about 10 or so minutes left. So what I wanted to do was just kind of open it up to everyone that is in the audience and make it an open forum. So there are a couple more questions in the chat. So I figured those participants can directly ask them in the open forum and just kind of interact with our wonderful panelists directly. So I'll go ahead and mute myself, and people just go ahead and talk in the chat and let's kind of communicate.
Hello. Thank you so much for, giving your time to us, honestly. I'm interested in dermatology and public health, and one of my mentors had some critical thoughts. He said that if you're gonna go into dermatology, you won't have as broad of a perspective to lead in public health. And I don't know, I guess I'm looking for some encouragement or advice on what that means and what your thoughts are on that. And also, this is my face, but I'm on my phone, so I'm gonna turn the camera off. Thank you.
I'm currently working with a student, I think that's a great question, who did a year in between her third and fourth year to get her NPH. And I am so excited for her. She's going into dermatology, and she has a perspective of skin health that's very different. It's on a broader scale. And so she's very interested. One of the studies she's looking at is environmental justice areas and the incidence of sarcoidosis. So what exposures are people having in their communities that can lead to sarcoidosis? And so I think she is so well equipped to do some very interesting studies in the field that have not been done because of this interest in public health. 1 in 4 people are affected by skin disease. How big or public health can you get? And so a lot of people are looking at big data, databases, public view, public approach to health. And I think that she's really going to crush it. She's really going to change the way that we look at dermatology, how we deliver care, the whole issue with Medicaid not being accepted that was brought up. Looking at policies, looking at the high level approaches to skin health. So I think that's a very powerful, dually approached field that you can do so much with. So I'm excited for you.
Thank you.
Any other questions?
You know that once people put their questions in the chat, they're never going to answer them in person. No one's going to ask them once they put it in the chat. They're like, I put it in the chat. Someone's supposed to read my question.
Hi, my name is Archania. I'm actually a third-year medical student at the Keck School of Medicine. Thank you all for being here. This was a really great and informative panel. I really appreciate all of your insight on the questions asked. I was just wondering if the panelists would feel comfortable putting their contact information in the chat should we want to reach out. Thank you.
I also had a question. I also put mine in the chat, so I wasn't sure if I should ask it again. But basically, I'm a medical student. I'm an M1. I go to Temple in Philadelphia, and I'm going to be doing research this summer in dermatology, specifically in hair loss. And to be very honest, my undergrad research experience was very limited. So although I'm very excited for this opportunity, I basically want to make sure I don't kind of mess it up, or that I go about it the right way and make sure I get the most out of the experience. So I wanted to know if any of the panelists had advice onto how to make the most of a summer of research in dermatology.
Yes, I do. I think that's very exciting. Congratulations, first off. And we need to have a lot of research done in hair loss. So that's a great field. So step 1 would be to prep yourself and figure out what the question is, if there's a specific question, and do your background research. So go through the literature, the past 10 years, and find out as much as you can before even entering the lab. So do your homework. know who your mentor is and who your team is, and know what they've done. So do your homework on them and know what type of work that they've done, the background. Be the most engaged team member that you can be. The little things that people do make a huge difference in a team setting. So just go in there. And I think it is okay when you introduce yourself and you get to know your team, is to let them know what your background is. And to phrase in a way that says that I don't have a lot of experience, but I'm a quick learner. I'm dedicated. I'm going to be persistent and persevere through this, and just let them know. And that kind of sets the stage. And then, every day, be diligent and, take notes and make sure that whatever you are assigned to do, you do. Now, the research you can't control, right? Sometimes you have a great research study, you get great results. Sometimes it's really slow, right? You don't have your reagents, things aren't working out. But what is most important is that you get the most out of the experience and you put the most into the experience, right? And so that means being a good team member, showing up, giving 110%. Somebody asks a question, they don't necessarily ask it of you, but you find out the answer. And I think that will be, regardless of what the data shows or the results, that will be a rewarding experience for you.
Okay, thank you so much. That was very helpful to me.
I'll just add on to that, just that I could kind of tell whether you were going to be in a basic science kind of lab or whether you were doing clinical research. But I think in addition to doing kind of that background research, I think it's always important once you're doing your reading is actually to think of questions that you find interesting. Because sometimes if you're doing clinical research, sometimes they want you to come up with your own project, or there's something, there's a way that you can work on something that you find interesting. So I think that that's the other thing, is that when you're doing your research, really write down your questions, that you have that you might want to study, like, such as sarcoidosis and, kind of in different regions, like whatever you're studying, just make sure that you are thinking about ways to kind of further the study in that field as well.
Okay. Thank you so much.
I love that last piece of advice. I think that is really, really great advice, because sometimes people that you may want to be your faculty mentors may not have a project that they could offer to you to work on at that time. And if you come to them with an idea for something that you're interested in, it might be something that they could create a project on with you, and something that you could work on together. So I think that piece of advice is really, really great, because I do think that sometimes you may run into something where, faculty says, oh, I'm really sorry, there's just no project that's going on right now. But if you have something, then that's something that you might be able to start and also see through from start to finish, which is always wonderful when you can kind of start a project and then see it through to the end and really make it your own.
Thank you so much.
Hello, everyone. My name is Muna Amarife. I'm a medical student in New York. First of all, I just want to thank you all, everyone who's on the panel. I'm really happy to be here, and my heart is really so full just having been able to witness all that's been shared today. So I had two questions. One I put in the chat, and I don't know if we'll be able to have time for the other, but the one I put in the chat, essentially, I was wondering, COVID-19 and the whole saga of it all has exposed a lot of things. One being the underrepresentation of minorities in clinical trials and research related to, how health and policy is carried out after research is done. And so that's across multiple specialties. And I wanted to know if there are any current or upcoming initiatives within DERM that are looking at how to improve Black and Brown participation in clinical trials and skin of color representation in these trial units. And if there are any ways that students could get involved in such efforts.
That's a great question. Our approach is a slower approach, and that's to build relationships and to build trust. And so we're not at the point where we're going in and just giving information about clinical trials. we're going in and delivering, skin health care into the community, developing partnerships, listening to communities, and then once we've solidified that, then introducing information. So I myself have stepped kind of outside of just dermatology and did a lot of work with vaccinations and education about COVID specifically. Again, just to get into the community and build relationships and really try to amplify their voices. Other ways that we're doing that, I work with medical students in the School of Medicine, is we're bringing community members and community activists into the School of Medicine. And they are a part of the medical school curriculum so that the students can hear what is happening in the communities, what are their interests, and what information they want to gain, so that you're not coming in to study me and with your agenda. If you want to make a study, let's sit down and talk about the study. And let's sit down and talk about what the community interest is. So I think that we have to shift our approach and start listening more about the community, and then come to some agreement about, how we do research, what are the diseases that are important to the community, and not just say we're going to recruit more Brown and Black folks to get into clinical trials. I think we have to kind of shift our framework of thinking before we get to that point. And I think that there are lots of ways that students can get involved with that.
Thank you so much.
Thank you so much. In the interest of time, I just want to go ahead and say thank you so much to our panelists. It has been an absolute pleasure to listen in on this panel. We are just honored to have been graced with all the information you have provided us and the resources. It has been great for you all to share your email addresses with the possibly interested students. So definitely please reach out if you are interested. That's something very gracious of them to do. And as we discussed, they are very interested in, answering questions and really helping anyone that may want to go into dermatology or learn more about it. So we will go ahead and say good night. I will turn it over to John to show you guys the link for the next event and the post-event survey. And I will just put a quick thing in. If our panelists and our planning committee can stay on at the very end of this, just for us to kind of take a group photo. Thank you.
Yes, I just want to echo that. Thank you everyone for joining us, and thank you so much to our panelists for taking the time to speak to us and sharing your expertise. So I'll just ask everyone to take a few minutes and fill out a quick survey for us, just so we can gauge how the event is going and see if there's anything that should be changed or altered or keep in mind for the next one. And I also want to invite you to join us on our next panel that's going to be looking into infectious diseases, focusing on STIs and HIV. And that's going to take place March 24th at 7:30 at the same time as today. So if you can scan the QR codes, one will take you to the survey and the other will be for the registration to the next event.
All right. Good night, and thank you, everyone. And we'll just stay on a few minutes with our panelists and our planning committee. We hope to see you next time.